Yeah. Hello, hello, hello. How are you doing? I'm sending out my little live stream here. I've seen some of my friends that met on TikTok for a while now. All right, who is here today? See two persons online. Oh, Champagne, how are you doing? Oh, you're at work? Okay, nice. How is that going? Hi, over on YouTube, how are you doing? If you're joining for the first time, I'm Stacy. Remember to go ahead and give the video a thumbs up and share it. All right, it's only inviting more persons over to the page. All right, that's all it's doing. Remember your daily heart meals as well as your what else? Your daily heart meals and your comments. Write your comments and share. All right, that's all. Work going well so far. Okay, nice. What area are you working? Champagne. Thank you for the heart me. And who is on YT here? Who is on YouTube here? Hi, welcome. Oh, you work in the NICU? Okay, nice, nice. Okay. That's nice. I did a little bit. It wasn't like a full NICU. In Jamaica, we had a, you know, it was a 4-no. Okay, what area you want to go in? Can't do deliveries. Oh, okay. Yeah, I wanted to do that. I wanted to do midwifery years ago, but you can't do deliveries. You're RN, so you're registered nurse midwife. So how you can't do? Oh, because you can't do deliveries. You don't want to stay there. Okay, I understand. I understand. Okay, I totally understand. All right. So tonight will be. Oh, you broke your hand. Oh, I'm so sorry. I'm so sorry. Tell me the left hand. Tell me the left hand broke. Oh my. I hope you'll get better soon. All right. I'm just limited. Yeah. Okay. Well, I'm glad it's a left hand. Well, not really glad that you broke your hand, you know, but at least it's a left hand. If you're not left-handed. Well, given the fact that you're typing so fast, I would say that you're not. Yeah, alrighty. So we're gonna do neurology tonight. We're gonna do the neurology system tonight. We have some questions prepared for that. So that's what we'll be looking at. No, right-handed, okay, nice. All right, so that's what we'll be doing. It's 7:02, I'm early today. Yeah, I'm very early today, which is good. I thought I was gonna be running late, but no. So how your day went otherwise? How your day went otherwise? And welcome, welcome everyone. And if you're new here, I'm Stacy, originally from Jamaica. I'm a nurse, trained in Jamaica, and then transitioned here to the States in 2016. Was doing traveling, went back to school, did my master's, and working as a house call nurse practitioner now. So this is, I'm enjoying social media. I'm enjoying, you know, what I'm doing on social media regarding, you know, just teaching or learning, because I'm learning as we go along as well. So I'm enjoying the content. So I do hope you guys will go ahead and follow me, subscribe to my page on YouTube as well as on TikTok here. It's ThinkNursing, one word. All right, so go ahead and follow. You'll hear more about me on my YouTube page because I share, like, you know, from a backbone, my background, a lot from my background on my YouTube page. So growing up in Jamaica, things like that. Yes, I'm a country girl. All right. What nursing school you attend? I attended Northern Caribbean University in Mandeville, Manchester. Yeah, so I come from Manchester, and I just never leave Manchester because I never have no money to go Kingston. You know, country girl would want to go to Kingston to study. Yeah, but no, that wasn't the case. I went to Northern Caribbean University, which is a Seventh-day Adventist university. All right, so did my training there, worked in Jamaica for 4 years at a public hospital. Learned a lot. It was amazing. You know, couldn't afford, you know, living in Jamaica. Let's just say it was expensive. I mean, never work enough money as a nurse. You understand? There wasn't much money coming in as a nurse back then. So, and I had student loan, and that was the most important thing for me. You know, clear my student loan. So I needed the opportunity, and so that's how I actually left Jamaica. You understand? There were recruiting companies in Jamaica, and I signed up with one, and you know, them never take me away, or them take me away for good, you know, as in I got the opportunity and I was, you know, working, able to pay off my student loan, and the opportunities just keep on coming. So that was just it. Would I go back to Jamaica to work? Yes, but not at the bedside. I love bedside nursing, but yeah, kind of passing stage there. I think I've done, how many years now? I've been working as a nurse since 2012. So I've done a few years at the bedside, you know, so I think it's time now for me to kind of step away from that. Okay. Oh, you went to EXED? Okay, nice. Kayla, welcome. How are you doing? All right, so tonight will be, and hello everybody. Remember to go ahead and top up the live. Please top up the live and share to just one person. Who is calling me, dear Father, at this time of the night? All of them spam call here. Goodness gracious. All right. So yeah, remember to go ahead and top up the live, and you know, the rule of the game is we'll just be answering questions and you share your input and we just make it fun. All right. So there are multiple choice questions. I'm giving myself until 9 o'clock. I know I talk a lot. So we'll try to just cover as much as we can tonight and then from there. All right. So choose A, B, C, or D. You're not going to let the patient die on you. So you have to choose the answer. You have to save the patient. I remember, always think of Maslow's hierarchy of needs in terms of answering the question. Look at comfort, safety, all of those things. Use the airway, breathing, circulation, assessment. All of those are what you're going to be using in terms of choosing the best answer for your question and moving forward. All right. Once we do that, then we're good. Hi, Marvin. Welcome. All right. So let us start with, and as usual, if you have a question, if you have a topic in mind that you want me to go ahead and prepare, feel free to go ahead and inbox me, and I'll definitely do that for another live. All right. Hey, Kayla. All right. So the first question, it is what, 7:06? Yeah. So the first question we have is, a 68-year-old man arrives with sudden right-sided weakness and aphasia that began 90 minutes ago. Which intervention has highest priority? I remember this is neurology, all right, neurological system. So a 68-year-old man arrives with sudden right-sided weakness and aphasia that began 90 minutes ago. Which intervention has highest priority? A, administer aspirin 325 PO immediately. B, obtain non-contrast CT of the head, no. C, start IV alteplase or TPA immediately. D, begin a 24-hour infusion of heparin. All right, so you have a 68-year-old man who arrives with sudden right-sided weakness and aphasia that began 90 minutes ago. Which intervention has highest priority? Is it A, administer aspirin 325 milligrams PO immediately? B, obtain non-contrast CT of the head, no. C, start IV alteplase or TPA immediately, or D, begin a 24-hour infusion of heparin. All right, remember you have to choose the answer. All right. The room is quiet. Kayla, I can see you trying to think of the answer there. Champagne, I know you're still there. Even though I don't see anybody typing or anything, but we need the answer. Shells, you're here. Shells is here. Shells says A. Champagne says B. Okay, so Shells is saying B, which is to obtain a non-contrast CT of the head. No. She had said to administer aspirin 325 PO immediately. All right. Do we have anybody on YouTube? All right. So seeing that we're kind of still warming up, we'll go with the two answers that we get. So definitely you don't want to get the CT scan of the head first. All right. I'm going to put this thing over here. All right. So definitely want to get the CT scan of the head first. What are we thinking about? Why you want to go ahead and do that? What diagnosis you're thinking? What is happening with this patient? CH312 says C, which is to start IV alteplase. You've gone very far though. CH312. So you're thinking that this patient is having a stroke. So the first thing you want to do is try to get a non-contrast CT scan of the head. No. All right. And why you want to look at that? Why you want to get the scan of the head? You want to look for any bleed before you can actually go ahead with your, your TPA. All right. So I want to make sure that this patient doesn't have a bleed before starting the TPA. All right. Without you having the CT confirmation, then the TPA would be contraindicated for this patient. So always try to get your patient directly to CT scan to get the scan of the head. And then from there, as long as there's no bleed, you can always go ahead with all of your other, your other treatment. For this patient with a stroke, if you're thinking about the stroke, you would want to withhold, anything that is oral. You don't want to be giving them the oral, aspirin there. So you can exclude that when you're using, you're looking at these and trying to remove what is incorrect. The answers that you're, omitting the answers that you think is not correct. Being a 24-hour infusion is not what you want. You always want to get to your, because what if this patient has a bleed? You don't want to start TPA. You don't want to be starting heparin infusion on somebody that has a bleed and then worsen the situation. All right. So all the other answers are contraindicated until you get your CT scan of your head. All right. A patient with suspected bacterial meningitis is admitted. Bacterial meningitis, what kind of precautions would you use for this patient? What kind of precautions would you be using for your meningitis patient? And if you're here for the first time, let's just try something. If you're here for the first time, just go ahead and put a heart in the comment section. So Island Girl says, hi, isolation. Yes, you will. But what kind of isolation are you going to put them on? I want to know the precautions or the PPE you'll be using for this patient. Is it like droplet? Is it airborne precautions? Contact precautions? CH12 says airborne. Okay. I always say whenever you're in doubt, go with airborne. You understand? You can't go wrong with that one. But the patient is going to be on droplet precautions. Yes, Shayna Williams, definitely. This patient is going to be on droplet precautions. All right. So you have a patient with suspected, I was looking for something else. So you have a patient with a suspected bacterial meningitis who is admitted. Which action is most urgent for this patient? A, start IV broad spectrum antibiotics after blood cultures. B, obtain MRI of the brain. C, place droplet precautions and wait for your lumbar puncture. D, administer acetaminophen for fever. So a patient that has suspected meningitis, bacterial meningitis that is admitted to your floor. Which action is the most urgent for you or the patient? A, to start IV broad spectrum antibiotics after blood cultures. B, obtain MRI of the brain. C, place droplet precautions and wait for lumbar puncture. Or D, administer acetaminophen for fever.
My arm hurts.
Your arm hurts? Oh, you've been exercising?
Yes.
Oh, I'm so sorry. All right, go exercise some more and bathe.
No.
Show me that his muscle hurts. Okay, so yes. So A, CH12 says to start IV broad spectrum antibiotics after blood culture. Definitely. Island Girl says A as well. So definitely you want to go ahead and get your blood cultures first for this patient. And then you will do your antibiotics. And just like any other patient that you're working up for sepsis or any form of infection, before you start your antibiotics, try and get your blood culture. Please, may I beg you no, try and get in the blood culture. Even if the doctor don't order it, just go run over and whisper to the doctor and say, hey doc, remember the cultures for this patient. You understand? Get the sample, put it down. Because sometimes, sometimes I feel as though, them don't want it, but then they do the blood and then the white blood cell can't come back or something else come back and it's elevated, lactic acid elevated, or the patient is just so confused. A lot of things going on and then them change their mind. So just be proactive and get your blood cultures, mark it, label it, put the time on it, put it down one side. It will come back very handy later on. At least you know that you did your blood cultures and then you do your antibiotics, all right? So definitely go ahead and obtain your blood cultures and then you go ahead and start your antibiotic because this will help with, delaying any issues there with, in terms of increasing mortality rate and all. You want to kind of cut down on that because we know that meningitis is something that nobody wants. You understand? You have to be very aggressive in terms of your treatment. All right, so drop net precautions are important, but initiation of your antibiotics is very important. What are some of the signs and symptoms or some of the classic signs and symptoms of meningitis that you tend to hear or see? Just go ahead and list a few of them in the comment section, except fever. We don't really want fever. All right, we know that fever is going to be there. So we're going to ignore fever. All right, so give us some of the classic signs and symptoms of meningitis. Pain. Okay, what kind of pain? Pain in where? Your knees or where you having pain? I remember this is we're learning as we go along. So try to just pull from, memory what you recall regarding meningitis. You remember the nuchal rigidity. All right, they tend to have the headache, the neck pain, the neck stiffness, things like those. The fever. Yeah. All right, so a lot of times they will have, especially with the children, they tend to have like poor feeding, things like those. All right, so always, sometimes they tend to be turning their head and they're having pain in their neck. Sometimes they can't really do anything like this because of the discomfort they're having in their neck. So those are some of the classic signs and symptoms. And as in terms of how advanced it is, the longer they're presenting with the symptoms, the more, the symptoms are in terms of severity. All right, so the pain might be worse, the fever might just be a little bit higher, things like those. All right, so you have a fever, headache, neck stiffness. All right, and those are the classic triad symptoms of or signs of symptoms of meningitis. Early symptoms include your headache, photophobia, nausea, vomiting, irritability, restlessness, muscle aches, and chills. The neurological signs are the altered level of consciousness, so they tend to become confused, drowsy, or sometimes can lead to coma. You tend to have seizures, positive Koenig sign, which is the pain resistance when extending the knee while hip is flexed. And you also have the positive Brzezinski's sign, which is involuntary hip knee flexion when the neck is flexed. So you guys need to know these. All right, you'll find them on the exam, confusing you guys. Koenig sign and the Brzezinski's sign. All right. For the infant and the neonates, the signs are different. You tend to have bulging fontanelles for the children, high-pitched cry, poor feeding, vomiting, lethargy, irritability, seizures, hypothermia, or fever. All right. And then you can have the meningococcal specific sign, which is the petechial or the petechial or the purpuric rash, which is a non-blanching red or purple spots, all right? And that's an emergency sign of Neisseria meningitis. All right, so just go through all of those because they're very common on the exam. As I say, all of these different signs when it comes on to like your appendicitis, your like Cushing's triad, all of those things. Definitely go ahead and read on them because you're gonna see them on the exam a lot. All right. Obtaining MRI of the brain, place the patient on that, administer Tylenol. All of those are important. All right, but the one that you want to go first with is trying to get the antibiotics started to get rid of that infection. All right. Remember to go ahead and tap up the live. Let's try to get the live tap up to 1,000. I'm going to be greedy tonight. Just 1,000. I see 7 person. Let's just exercise these fingers so we don't have arthritis killing us. All right, let's just tap up the live. I see 3 persons on YouTube here. Okay, go ahead and just give the video a little thumbs up. It's not going to hurt. It's not gonna hurt. All right, it's not gonna hurt. All right, yes, Kayla, thank you so much for doing that. Live Shines, welcome as well. All right, so let's go on. A patient with increased intracranial pressure has Cushing's triad. Which sign is part of that triad? All right, so you have a patient that has increased intracranial pressure and has Cushing's triad. Which sign is part of that triad? Is it A, rapid shallow respirations, B, widening pulse pressure and bradycardia, C, tachycardia and hypotension, or D, pinpoint pupils and hyperreflexia? So you have a patient that has increased intracranial pressure. This patient has Cushing's triad. Cushing's triad, which sign is part of that triad? A, rapid shallow respirations, B, widening pulse pressure and bradycardia, C, tachycardia and hypotension, D, pinpoint pupils and hyperreflexia. So Shell says B, Island Girl says B, Jacqueline Masio Wagwan, welcome, welcome, welcome. All right, Rupert, thank you so much for joining in. All right, so we say here B, widening pulse pressure and bradycardia. All right, so you tend to have the irregular respiration and the widening pulse pressure, bradycardia, which are all late signs of increased intracranial pressure. All right, which position would you put a patient in? If you have this patient that is having or exhibiting signs of increased intracranial pressure, which position would you be putting this patient in bed? All right, what position would you put this patient in and why? Island Girl says flat. Denise says side. Welcome, Denise. All right. So you have a patient with increased intracranial pressure. Just think of it. You have a patient with increased intracranial pressure. Which position would be best suitable for this patient? Kayla says semifolars. Okay, why you say semifolar position, Kayla? Why you think that position is best suitable for the patient? Jacqueline says up. Okay. All right, Jackie, why you say sitting 90 degrees, Denise? Okay, so you want to put the patient in semifolars position just because you don't want it to be a case where you're increasing, based on the position of the patient, you're causing further increase in that intracranial pressure. All right, so anywhere between semifolar would be a good position for that patient. All right. Then the other thing we have here, reduce pressure. Yes, it will reduce the pressure on that for that patient. And what medication would you be thinking about? If you have a patient that has increased intracranial pressure, what medication can you think of that will help with reducing that pressure? So if the doctor say, hey, Stacy, run and get that medication from the Pixies, what medication you'll be thinking of to help with reducing the pressure for your patient here? Manitol, Tanisha, welcome, welcome. Diuretic, yes. Diuretic, mannitol, yes. Anything that will reduce your where is that? I can't see it, probably because of the direction. So definitely you will go ahead and give your diuretic that is going to help with pulling some of that fluid from the patient's, brain there. All right. So definitely go ahead and grab your mannitol. They have another one that you can also get, your hypotonic saline. Okay. Anything else we can think of apart from mannitol and there is another one. I'm going to tell you. So they're considered to be osmotic diuretic. So yeah, as osmitrol, that's what I was thinking. It's the same thing as the mannitol, Tenisha. Yeah, that's the one I was thinking. All right. But that's the one you'll be thinking about. And it is usually used for, cerebral edema, acute glaucoma, prevention of renal failure, drug toxicity. You can use your osmitrol or your mannitol for. All right. Okay. The other one here, which patient would you be thinking about with pinpoint pupils? If a patient that comes in with pinpoint pupils, what patient are you thinking about, or what's going on with that patient? If you have somebody that comes in with like your pinpointed pupils, what are you thinking about for that patient? Glaucoma. I don't really know. So glaucoma. And what about your overdose patients? A lot of times they come into the hospitals and they have like your pinpointed pupil as well. So would it be like the close angle? Is it like the close angle glaucoma you're thinking, Denise? Or your open angle glaucoma? All right, so you have patients who have like, your overdose patients tend to have your pinpointed pupils. Yes, okay. And so definitely you'll see those patients with your who have glaucoma. So you'll have like your pilocarpine eye drops that you can actually use, or some of those medications tend to cause it. You were thinking overdose? Okay, yes. All right. Rapid shallow respirations. Okay. So Cushing's triad, widening pulse pressure is one of the feature, bradycardia, irregular respirations, and all of those are late signs of increased intracranial pressure. All right. You have a client with Parkinson's disease who reports difficulty swallowing, all right, and frequent aspiration. Which dietary instruction is best? So a client with Parkinson's disease reports difficulty swallowing and frequent aspiration. Which dietary instruction is best? A, provide pureed foods and thickened liquids. Sit upright and tuck chin while swallowing. B, recommend thin fluids and small frequent meals. C, encourage liquids with meal to wash solids down. D, place patient in supine position for meals to relax the neck muscles. All right, so which is the best answer? Denise says pureed, okay, which is A. Island Girl says A. Okay, nice. So definitely you want to go ahead and give the patient anything that is thickened liquids, pureed foods, anything like that, keeping them upright. All of that is going to help with preventing aspiration. If this patient is having problem with swallowing and is always having, or is exposed to aspiration in the past, you don't want to give them like, a lot of fluids, all right, because that is just going to worsen or cause them to continuously be aspirating, all right. So recommending thin liquids and small frequent meals. Definitely small frequent meals are fine, but the thin liquids is a problem. All right, so anything with a lot of liquids is gonna be a problem. So the other options are incorrect. So you wanna go ahead and do the pureed foods, thickened liquids, sit upright, and tuck the chin while swallowing. All right, all of those are gonna help with reducing aspiration that is due to the dysphagia, the difficulty swallowing for this patient. All right. A patient experienced a generalized tonic-clonic seizure and is post-ictal. Which nursing action is most important? So you have a patient that is having seizure. They're having generalized tonic-clonic seizure. And how you know when a patient is having a tonic-clonic seizure? What are some signs or that you might see for a patient that is having a seizure? Go ahead and just put them in the comment box below. What are some of the common signs of a patient having a seizure? Thank you guys for liking up the live. And Tasha21, thank you for following. So a lot of times you might have the generalized shaking, jerky movement of the patient, the eyes rolling over, foaming of the, foaming from the mouth. A lot of times they tend to bite their tongue. Some persons become incontinent. They lose their bowel or they pee on themselves. So all of those things you can always say, hey, did the patient pee on themselves or poop on themselves? And once they tell you that, or if they bite their tongue, definitely they had a seizure, a real seizure episode. All right, so you have this patient who is having generalized epilepsy, yes. So you have a patient that is experiencing generalized tonic-clonic seizure and is post-ictal. And a lot of times after they've had their seizure, they tend to fall asleep. You understand? Them just start snoring down the place. Yes, they're in the post-ictal stage of their seizure. So which nursing action is most important for you at that time? All right, which nursing action is most important immediately? A, insert an oral airway. B, monitor airway breathing and oxygenation. C, administer IV lorazepam. D, obtain a CT scan. So you have a patient that experienced a generalized tonic-clonic seizure and is post-ictal. Which nursing action is most important? All right, what is it that you're going to do immediately for this patient? A, insert an oral airway. B, monitor airway breathing and oxygenation. C, administer IV lorazepam. Or D, obtain a CT scan. So B, nice. So you want to go ahead and monitor airway breathing and oxygenation for this patient. All right, that is most important. All right, you don't want to go ahead and give your IV lorazepam because the patient is not having an active seizure. All right, you always go ahead and do that whenever they're having the ongoing seizure activity. So this patient experienced a generalized tonic and a clonic seizure, and the patient is post-ictal. So you don't need to be giving the IV lorazepam at this time. You don't want to put anything in the patient mouth, all right, while they're having their seizure episode, because you don't want to bite, you don't want them bite off your finger. All right, so do not put anything in the patient's mouth at that time. Seizure is over, no C unless it continues based on orders. Definitely Jatin. Yeah, we're gonna say Jatinifia. Welcome. All right, so hold off on the lorazepam unless the patient is having, continuous seizures. Then you can go ahead and do that. Avoid putting anything in the patient's airway, in the mouth, because you don't want further problems, all right, to be happening to you as well as with the patient. Obtaining a CT scan, definitely after they will, get a CT scan just to make sure that everything is okay. All right, so after seizure, maintaining airway breathing and monitoring oxygenation are immediate priorities. Sometimes you can go ahead and just, have the patient, put the patient on a little bit of oxygen, because sometimes their oxygen saturation, will drop after that event. So just go ahead and put them on a little bit of oxygen to help with, improving their oxygenation. Sometimes you might just need to go ahead and suction the patient because they might just have a lot of, a froth in the mouth. They probably bit their tongue, they're bleeding, things like that. Go ahead and suction the patient to make sure you're clearing that airway there and prevent any further like aspiration or anything like that. All right. Benzodiazepine are for ongoing seizure activities if there is an order for it. All right. So which finding suggests a subarachnoid hemorrhage rather than a migraine? So a patient that comes in, which finding suggests that this patient is having a subarachnoid hemorrhage rather than a migraine? A, recurrent unilateral throbbing headache with photophobia. B, sudden worst headache of my life with neck stiffness. C, headache improved by sleep. D, headache associated with a aura lasting 30 minutes. So which finding suggests a subarachnoid hemorrhage after migraine? Is it A, recurrent unilateral throbbing headache with photophobia? B, sudden onset of worst headache of my life with neck stiffness? C, headache improved with sleep? Or D, headache associated with an aura lasting 30 minutes? Worst headache, BBB. I see Jane Francis says recurrent unilateral throbbing headache with photophobia. Okay. All right, so everybody that says B is correct. The sudden worst headache of my life. Anytime I hear a patient say that them having the worst headache of them life, or they feel as though somebody lit them in them head, you understand that's you don't want a patient tell you that. All right. So always just be thinking about a bleed whenever anybody says that to you. All right. So the sudden onset of worst headache of my life with neck stiffness is the one that is suggesting a subarachnoid hemorrhage. The others are more for migraine. You might hear, you might have the unilateral throbbing sensation in your head, photophobia, very sensitive to light. You might have the headache that improves with sleep. Things like those, are more for your regular headaches or your migraine. But your subarachnoid hemorrhage is usually the worst headache of my life. And make sure you're checking all of those patients and in pupils as well. All right. Make sure you're checking the pupils of those patients. All right. So sudden severe headache with neck stiffness suggests subarachnoid hemorrhage, and this is a neurological emergency requiring urgent imaging. All right. A lot of the patients that are elderly, they tend to be, at risk for these kind of bleed as well. All right. Especially because they keep on falling. A lot of them tend to fall and they don't report it to anybody. So they tend to have a lot of subarachnoid hemorrhage, like days later, them start stroke out. So definitely observe your patient. If you realize for your elderly patients, you notice any bruising, anything like that, and you think they had a fall, even if, if they said they never hit them head, but if you hear that they never have anybody there with them who witness it, just always go ahead and advocate for them to get a CT scan, especially if you realize that, they're acting a little bit different than their usual. If you've been around them for a while, try to go ahead and get a CT scan of the head to make sure that there is no bleed going on. All right. A patient with suspected acute ischemic stroke arrives 3.5 hours after onset, which is an exclusion to IV, TPA, or your alteplase. All right. So you have a patient who has a suspected acute ischemic stroke arriving 3.5 hours after onset, which is an exclusion for your IV, TPA, or alteplase. A NIHSS score of 12, which is the stroke evaluation there. All right. The NIHSS score of 12. B, a blood glucose of 60 milligrams. C, a platelet count of 150,000. Or D, recent intracranial hemorrhage 3 months ago. All right. So a patient with a suspected acute ischemic stroke arriving 3.5 hours later after the onset. All right. Which is an exclusion for IV TPA. A, NIH score of 12. B, a blood glucose of 60. C, platelet count of 150,000, or D, recent intracranial hemorrhage 3 months ago. Thank you, Diva, for the follow. And remember to go ahead and tap up the live so we can get it, sent out to all the other persons on the platform here. And thank you all the other ones who have been following as well as, joining in on the live. All right, thank you, Erica. So Denise says A, the NIH score of 12. Do we have anybody else who want to compete with Denise on that answer? So you have a patient that has acute ischemic stroke arriving 3.5 hours after onset, which is an exclusion to IV TPA. What is TPA? What is TPA or alteplase? What kind of drug is that? What kind of drug is your alteplase or your TPA? A clot buster, definitely. So, what was it? Denise, I know you says A, NIH of 12. Do you want to reconsider your answer? So the question is, a patient with a suspected acute ischemic stroke arrives 3.5 hours after onset, which is an exclusion to IV TPA. Who you want to give a give the clot buster to because of any one of these 4 options? Is it the NIH that is a score of 12? Is it the blood glucose that is 60? The platelet count of 150,000? Or the recent intracranial hemorrhage that is 3 months ago? Diva says D. Okay. Yes. So remember, what are some of the contraindications to giving a patient, your TPA, your alteplase, any form of clot buster, your heparin? If a patient says that they have a bleeding ulcer, you want to kind of, hold off on that. If they've had any form of surgery, weeks ago, months ago, you want to hold off on that. You understand? Those patients are not candidates for your TPA or your alteplase because of the risk for bleeding. All right. The patient had a recent intracranial hemorrhage. So the patient has had a brain bleed before 3 months ago. You want to hold off on that because you don't want to give it to this patient and then cause worsening with their intracranial bleed. Even though it's 3 months ago, this medication is very, very powerful. Yes, it's very, very powerful. I've seen patients, come in and them can't talk, and in a 15 minutes them start talk to me after giving these drugs. It made me nervous when I giving it, but it's very powerful. So you have to be very, very cautious with the patients that you're giving it to. So the patient that is gonna be excluded is the one that has the recent intracranial hemorrhage 3 months ago. All right. So it's an absolute contraindication to TPA. The others are not as absolute exclusion. All right. But you also, for the patient that has a glucose of 60, you definitely want to make sure that this patient is not hypoglycemic and having stroke-like symptoms because of the hypoglycemia. So you want to correct the hypoglycemia before you move forward. So if you have a patient that comes in, if you hear about a patient that is coming in and they say the patient is having like stroke-like symptoms, always make sure you get your glucose to make sure it's not hypoglycemia. The patient just needs a little bit of, glucose. The patient needs a turkey sandwich to eat. You understand? So make sure we check the glucose first and correct that before we go ahead and, do all of these things with, the TPA or getting the patient to CT scan. All right, get your glucose first. A lumbar puncture shows cloudy CSF, low glucose, and neutrophil predominance, which is most likely. So you have a patient that you did a lumbar puncture on, and it shows cloudy CSF, low glucose, and neutrophil that is predominantly in the sample. Which is most likely? Is it A, viral meningitis, B, bacterial meningitis, C, subarachnoid hemorrhage, or D, fungal meningitis? Thank you, Diva. So she says she loved the content. So if you haven't followed us, go ahead and follow. All right. Wink, wink. All right. Jane Francis, nice. So she says B, bacterial meningitis. Let's see who else have another answer. So a lumbar puncture shows cloudy CSF, low glucose, and neutrophil. All right. Which is most likely? Is it A, viral meningitis, B, bacterial meningitis, C, subarachnoid hemorrhage, and D, fungal meningitis? So B and bacterial meningitis, definitely that is it. Anytime you see anything cloudy, milky, white, just think about bacteria. All right. That is going on. Bacteria feeds on glucose, definitely. All right. And most of the time you have your lumbar puncture done on your meningitis. So even if you're not so familiar with, the lumbar puncture procedure or meningitis itself, just think of it that lumbar puncture, most of the time they're going in your, your spinal column there, trying to get some of that CSF there. All right. And it's most of the time for like your CSF and all they're checking. All right. For meningitis. So with bacterial meningitis, you tend to have the cloudy fluid, low glucose, and the neutrophils, which is indicative of that. All right. How often do you see anybody doing subarachnoid, lumbar puncture for subarachnoid? I've never seen it, heard it for subarachnoid hemorrhage. So that is just something to confuse you. All right. So a lumbar puncture shows the cloudy CSF, low glucose, and neutrophil. It's most likely your bacterial meningitis. All right. And as we say, for this patient, once you're suspecting it, go ahead and get the patient on the droplet precautions. All right. And make sure you get to your cultures first before your antibiotics. All right. And and another thing, I know there was this hospital that I was working at, and it makes sense. If you get any of these sample that is so hard to get, so if you're doing any aspiration, any body fluid except urine and blood and urine can go through the tube system. So you have some hospitals that have tube system that it's sent from here, so over to Timbuktu, the sample to the lab. Yes, you can always do that for your blood and your urine. But me I beg you, please, if you get on a CSF and if you get on a aspiration, like sometimes you do the knee aspiration, and you have those samples to send over. Me I beg you, do. Now send it through the tube system. Do not walk with it to the lab or have somebody just walk with it over to the lab. All right, those samples are very delicate. So you don't want it to get stuck in the tube system and then the patient is suffering again to get those procedures done. All right, so always walk with those samples. I hold them very, very close to my heart. Not saying the blood and the urine is not that important, but God bless, like that's the least we can do. Walk with your sample over to the lab and hand it off, because the CSF and your other, fluids that are very, very hard to come by, you put the patient through too much to get it. All right, so walk over or send somebody over to the lab with the sample rather than sending it through the tube system. All right. All right, let's go. So a client with elevated ICP or intracranial pressure is being given mannitol or osmitrol. Which monitoring parameter is most important? What is the normal range for your intracranial pressure? What's the normal range you're looking for? I think it's like say 10 to 16 or something like that. 5 to 15. Yes, Jane. Nice. So 5 to 15 is your normal intracranial pressure reading. All right, millimeters of mercury. It is increased whenever it is greater than 20. All right. So 5 to 15 is your normal intracranial hypertension, your intracranial pressure. And anything over 20 is considered to be elevated. All right. 20 millimeters of mercury is considered to be sustained and it's a medical emergency. All right. And they'll do the lumbar puncture. And try to get some of that fluid down. All right. Get some of that fluid off to reduce your intracranial pressure. All right. So a client with elevated ICP is given mannitol. Which monitoring parameter is most important? A, serum potassium every 8 hours. B, urine output and serum osmolality. C, liver function test. Or D, platelet count. So you have a client with elevated intracranial pressure that is being given mannitol. Which monitoring parameter is most important for you or for the patient? A, serum potassium every 8 hours. B, urine output and serum osmolality. C, liver function test. Or D, platelet count. So Vanessa says serum potassium. Denise says serum potassium A. Jane Francis says B, urine output and serum osmolality. Okay, do we have anybody on YouTube here saying anything? I noticed we're mute for a little bit. Welcome. How are you guys doing? And thank you so much for joining in. I'm Stacy. Go by the, ThinkNursing. Follow me here on TikTok as well as on YouTube at ThinkNursing, where I share content related to nursing, travel, and lifestyle. But anyways, we do live stream on Thursdays and on Tuesdays. All right, study session. So join us as well. All right, so we see Holy File says AA. So I have a lot of persons that are saying serum potassium every 8 hours. So the one who had said, I think I saw a few persons that says B, urine output, or one person that says urine output. Jane, why did you say urine output? Why you want to go ahead with that? Tony, hello, hello, hello. Why you want to go ahead and monitor that parameter there, the urine output and serum osmolality? So remember that, you know, what kind of drug is mannitol or osmitrol? What kind of drug is it? It's a diuretic, all right? It's a diuretic. Okay, no problem, Kerry. Thank you so much. It's a diuretic. So one thing you want to, you know, you don't want the patient to do is be dehydrated from you pulling all of that fluid. All right, with that medication there. So the serum potassium every 8 hours is fine to monitor that. All right, but I think the one that is most important is your urine output. All right, you want to make sure you're not pulling too much, because if you're able to monitor that parameter as well, you'll be able to kind of have an idea of whether or not this patient is losing too much potassium as well. All right. So mannitol is a osmotic diuretic. Monitoring your urine output and your serum osmolality is to help with avoiding dehydration for this patient, as well as hyperosmolality. All right. So as I said, serum potassium every 8 hours, that's fine. But I think probably if you have a patient that is on mannitol, you probably want to look at your potassium a little bit like closer in terms of time period. I think 8 hours is a little bit too long to be looking at those numbers. So that's just me. I would probably just do ISTAT and look at what the potassium is, because as I say, it's a very strong medication in terms of the amount of fluids it will be pulling. So you definitely want to probably keep a closer eye on, you know, on the potassium, because of the risk for arrhythmias and everything. And then from there, but the one that is most important here is going to be your urine output. All right. And your serum osmolality. What was your study method for pharmacology? Oh, let me just read the textbook in a dear. I just read a textbook and I did use a lot of I read a textbook that I got. I use a lot of YouTube videos. You know, I find different websites for, not really website, but like on YouTube they have a few persons that does really good content regarding, you know, medication and all. So I did use those, and there is Quizlet as well. So I use Quizlet for, like, you know, flashcards and all, and then from there. But for me, it's more, once I understand the mechanism of action as best as I possibly can, then I can relate to, you know, whatever situation there is. But that's about it. Yeah. Hope that helps, Denise. All right. So definitely your mannitol, you want to look at your urine output and your serum osmolality. All right. Liver function test, is that very, very, very important right now? Is the liver function, like, you know, something that you want to be keeping an eye on for this patient with increased intracranial pressure? For me, it's no, you know, no, not for me right now. Platelet count, definitely I'll keep an eye on that as well. But the mannitol and the urine output is very important. All right. A patient with a right middle cerebral artery stroke, MCA stroke, is most likely to demonstrate which deficit? All right. Is it A, left harmonious hemanopia and left hemiparesis? B, loss of proprioception on the left only? C, bilateral sensory loss? Or D, pure ataxia without weakness? All right. So patient with right middle cerebral artery, or MCA stroke, is most likely to demonstrate which deficit? Is it A, left harmonious hemanopia and left hemiparesis? B, loss of proprioception on the left only? C, bilateral sensory loss? Or D, pure ataxia without weakness? So Jane says A, left harmonious hemanopia and left hemiparesis. All right. So the MCA stroke tend to cause, you know, left hemiparesis, sensory loss, and left visual field cut. All right, so we'll read up on that one. All right, go and read up on that one regarding the different types of stroke. All right, and what kind of deficit the patients tend to have regarding the kind of stroke they're having. All right. Which medication is first line for status epilepticus? And how you know when a patient is in status epilepticus? What's the difference between status epilepticus and seizure? How you know that the patient is in status epilepticus? Recurring seizures, yes. All right, so when you have recurrent seizure episodes, then definitely that patient is in status epilepticus. All right, so which medication is first line for status epilepticus after initial benzodiazepine? And give me one example of a benzodiazepine that we tend to use for our seizure patients. Dilantin, Valium, lorazepam, all of the PAMs. All right, you have your lorazepam, diazepam, Valium, Xanax, clonazepam. Those are different medication. What's the antidote for a patient that has gotten too much of benzo? So if a patient that comes in and they're overdose on Xanax, what medication you'll be given to reverse that? Midazolam, yes, Tanisha. What medication you'll be using for, yes, the flumazenil, all right? You'll be using to reverse your benzo overdose. All right, so you have a patient that is in status epilepticus. What medication is the first line for status epilepticus? Oh, goodness. After initial benzodiazepine. Is it A, phenytoin, B, carbamazepine, C, Keppra, IV, or D, phenobarbital? So which medication is first line for status epilepticus after initial benzodiazepine? A, phenytoin, B, carbamazepine, C, Keppra IV, or D, phenobarbital? B, Jane says B, carbamazepine. Do we have anybody else with another answer? Island Girl says C, Keppra. Keppra. All right, so the answer is a phenytoin. All right, so which medication is first line for status epilepticus after initial benzodiazepine? Is gonna be your phenytoin. All right, and it says that after benzodiazepine, IV phenytoin is commonly used. Keppra is an alternative, but the phenytoin is a standard for many protocol. All right, so after you've given like your lorazepam to break that seizure, they'll always want to start with your phenytoin. All right, and then you have some facilities that will go ahead and do your Keppra. So go ahead and follow whatever the policy is for your hospital. But if they're saying, hey, grab the medication, run for your phenytoin first, and then from there. All right. A patient with a 45-year-old has unilateral facial droop and a loss of taste to the anterior tongue. Which nerve is involved? So you have a 45-year-old who has unilateral facial droop and a loss of taste to the anterior tongue. Which nerve is involved? Is it A, the facial nerve, which is nerve number 7, the trigeminal nerve 5, the glossopharyngeal, which is 9, or the D, vagus nerve, which is 10? So you have a 45-year-old who has unilateral facial droop and a loss of taste to the anterior tongue. Which nerve is involved? Is it the facial nerve, trigeminal nerve, glossopharyngeal nerve, or the vagus nerve? Jane says A. Okay, do we have anybody else with another option? So the facial nerve, definitely you have the facial, the nerve palsy causes facial droop, and it also have the patient losing their taste to the anterior 2/3 of their mouth. All right. So there is a way for you to actually remember the different nerves and the numbers. So try to remember that. There's a mnemonic. I think I hear about 10 different mnemonics. I think I remember mine as O, to touch and feel a girl's V, and hips. Yeah, that's how I remember it. So you can actually know that, you know, number 1 is O, you know, yeah, you'll write it down. So try to remember the different nerves so that way whenever they ask you which nerve is being affected, you can always remember it. All right. But the unilateral facial droop and the loss of taste to the anterior tongue is going to be your facial nerve. Trigeminal nerve is nerve number 5, glossopharyngeal is 9, and the vagus nerve is 10. All right, and facial nerve is number 7. All right. A patient with increased intracranial pressure develops unilateral dilated pupil that reacts poorly. This suggests to say I have a patient that has increased intracranial pressure that develops unilateral dilated pupil that reacts poorly. This suggests A, oculomotor nerve, which is number 3, compression from the uncal herniation. B, isolated cranial nerve 2 lesion. C, meningitis, or D, early Alzheimer's disease. So a patient with increased intracranial pressure develops unilateral dilated pupil that reacts poorly. This suggests oculomotor nerve compression from the uncal herniation. B, isolated cranial nerve 2 lesion. C, meningitis, or D, early Alzheimer's disease. So we'll choose which of the answer. So Jane says A, oculomotor nerve compression from uncal herniation. Do you have anyone else with another answer? Oh, okay. So Jane says oculomotor nerve compression. So the oculomotor nerve is nerve number 3, and the oculomotor nerve, that is, so you have, what I was going to ask a while ago. So with the early Alzheimer's patient, what are some of the, what is the sign? How you know that a patient is having Alzheimer's? What is happening with their memory? Is it like sudden onset of memory, you know, deterioration, or is it something that is progressive? How would you know that this patient is having Alzheimer's? What was I going to ask about the ocular motor? So usually it's something that happens, you know, over time. It's not something that is sudden, all right? It's not something that happens suddenly. It's something that progressively worsens over time. So you'll notice that they're having change in their behavior, memory loss, things like that is happening over time. And then with meningitis, we know that as we talk about, you know, the different signs of or the symptoms of meningitis. So the patient that is having unilateral dilated pupil, that reacts poorly is because of the ocular motor, because you know it's affecting the eye. All right, so definitely an enlarging poorly reactive pupil suggests cranial nerve 3 compression, and it's typical of uncal herniation, and that is a neurosurgical emergency. So if you see a patient, that's why it's very important. Sometimes the patients are sleeping and you just be like, oh, you don't want to wake them. No, for your patients that have like, any form of brain injury, trauma, you're thinking about, changes going on in their brain with their intracranial pressure. Open them eyes and look at them pupil. Yeah, man, shine the light into them eyes and see how reactive their pupils are, because that is very important. I don't want it to be a case where you just feel as though the patient is sleeping and you don't realize that one pupil is like blown. You understand? So definitely open the eyes, shine your light in the patient's eye, and look at their response with their pupil. All right. And then from there. Thank you for the roses. TS. Shelly Mar, thank you so much for joining in. Erman, thank you. All right. For a patient that is undergoing EEG for seizure localization, which instruction is most important before the test? A, withhold anticonvulsive medication per the provider's orders. B, do not sleep for 48 hours prior. C, eat a heavy meal to avoid hypoglycemia. Or D, take all usual medications. So I have a patient that is going to go undergo EEG for seizure localization. Which instruction is most important before the test? A, withhold the anticonvulsant medication per the provider's order. B, do not sleep for 48 hours. C, eat a heavy meal to avoid hypoglycemia. Or D, take all usual medications. So Jane says B. Thank you for the follow, San. All right, do we have anyone else who has another answer option? So you have a patient that is going to go and do a test, a EEG. What's a EEG? What's a EEG? Sorry, and get down. So you have a patient that is going to go and do a EEG. What is that? So you're looking at the electrical activity in the brain. So it's an electroencephalogram. So electroencephalography, all right, it's a medical test that measures the electrical activity in the brain. It records brain waves using electrodes placed on the scalp. So if you have a patient that is having seizure, we want to see what's happening with their brain activity. You don't want to have them take their seizure medication that is going to help with, preventing or controlling that electrical signal in their brain. You want to tell them, hold off on the medication as per your doctor's order. So when they go in, if they're having a seizure, at least they can see what's happening during that time period. So they hold off on their medication based on how the provider says to hold off on the medication before the scan and then before the test. And then from there, they'll be able to see the true picture of what is going on in that patient's brain. All right, do not sleep for 48 hours. No. Eat a heavy meal to avoid hypoglycemia. You don't really want to eat a heavy meal. Just eat your regular meal. You understand? You don't want to go there with your belly too full. Alright, so definitely just eat, small meal, something to prevent hypoglycemia. But the heavy meal, I would say avoid that. Take all medications as usual. No, because as I say, if you have your anticonvulsant medications, you want to withhold those medications as per the order to prevent you masking or preventing any form of electrical activity from going on that is a true reflection of the patient having a seizure or, just what their normal brain activity looks like. All right. So anticonvulsants may be withheld under direction to increase the chance of capturing those epileptic form activity. And, specific orders vary. So definitely go ahead and instruct the patient to follow their provider's order. All right. A client with multiple sclerosis shows new optic neuritis. Which treatment is most appropriate for this patient acutely? All right. So a patient with multiple sclerosis who shows new optic neuritis. What are some of the signs of, new optic neuritis that patients tend to have? So a patient that has optic neuritis, what are you thinking about in terms of some of the signs and the symptoms for this patient? Sorry, Ann. So it's basically the vision loss, yes. So you have the inflammation taking place on the optic nerve. So the person might have blurred vision, they might have vision loss Sometimes they might have like, you know, pain, things like those going on because of that damage there. So for the patient that is having this kind of condition going on, what is it that in terms of the medication you'll be giving this patient? So which treatment is most appropriate for this patient acutely? Is it A, high dose of IV corticosteroids, B, long-term low dose of prednisone only, C, immediate plasmapheresis as first-line treatment, or D, oral antibiotics? So you have a patient that has multiple sclerosis and the patient shows new optic neuritis, which is an inflammation of the optic nerve. Which treatment is most appropriate for this patient? Is it A, high dose IV corticosteroid, B, long-term low dose prednisone only, C, immediate plasmapheresis as first line, or D, oral antibiotics? Jane says C, immediate plasmapheresis as first line. Champagne says D, oral antibiotics. All right, so remember this patient has inflammation of their optic nerve, and one thing you want to do is preserve their vision. All right, you want to go ahead and preserve their vision, and if you have inflammation taking place there, you want to go ahead and start with your IV medications of corticosteroid to help with that inflammation, that swelling, all right, to preserve those nerves there. All right, so definitely you'd go ahead with your high dose of your IV corticosteroids. All right, oral antibiotics, you don't know. And then any form of oral medication is going to take a little bit longer to work. So you always want to go with the ones that are, just remember, it is something that is a emergency. All right, so you want to go ahead and preserve the sight of this patient. So the oral medication is going to take a little bit longer. For maintenance, probably that will work, but you want to start with anything that is IV. Long-term low-dose prednisone only. Always remember, for the exam, anytime you see the word only, just ignore that one. Remove it. All right, because there are other things you can do for the patient. It's not only prednisone only. There are other things that you'll be doing. All right, immediate plasmapheresis as first line. Plasmapheresis is for steroid refractory cases. So that is not what you're going to be doing at that time acutely. You want to go with your high dose of corticosteroids and then from there. All right. So acute multiple sclerosis exacerbations like optic neuritis are commonly treated with high dose IV steroids. All right. So all the other options are incorrect at this time. Hi, Mona. Welcome, welcome. Carousel, thank you for reposting the video. All right, let's try and see if we can tap the screen up to 3,500. Not gonna be needy. All right, let's see if we can give the video a like so we can get it to other persons out. All right, so we can have more persons coming onto the live. All right, so we'll try to go up to 3,500 and then from there. And if you're new here, I'm Stacy. Welcome. All right. Get on my bicycle. Onto your bed. All right, so yeah. So let's try and get the live up to the 3-5. What time is it? 11 past 8. Okay. So nobody know want to work on a finger tonight? 1 little top? Just 1 little top? Is it that bad? Thank you, son. Thank you, thank you, thank you. Thank you for doing that. Sharon Muir, welcome. All right. See, that's no holding off on no tops. All right. That's fine. We'll be continuing. All right. We'll be continuing. All right. So let's get this other question going. All right. So a patient with suspected trigeminal neuralgia asks about a first-line medical therapy. The nurse should expect which drug? Is it A, carbamazepine? What's the other name for carbamazepine? What's the other name for carbamazepine? Is it Tegretol? Tegretol? Yes, Jerry Tegretol. All right, so the other name for carbamazepine is Tegretol. All right, gabapentin only. Is it C-prednisone or SSRI antidepressants? So you have a patient with suspected trigeminal neuralgia who asks about a first-line medical therapy. Which drug is the nurse thinking or expecting to tell this patient? Is it A, carbamazepine, B, gabapentin only, C, prednisone, or D, SSRI antidepressants? Which medication will you tell this patient that is the first line treatment for trigeminal neuralgia? Thank you for the follow, Natalie Ellis. Forever blessed, welcome. I haven't seen you guys in a long time. All right, so Tegretol, oh, definitely. So well, I don't know if you guys were answering to the carbamazepine other name, or you're giving the answer for the question. All right, but carbamazepine is the medication that is the first line treatment for trigeminal neuralgia. All right, and it's a sodium channel blocker. And if you're not familiar with trigeminal neuralgia, it is also called tic douloureux. Oh, yeah. It is a chronic nerve disorder that causes severe, sudden, and excruciating pain in the face. All right. And they say it's believed to be related to compression or irritation of the trigeminal nerve, which carries sensory information from the face to the brain. What nerve is that? So the trigeminal nerve, which nerve is that? What number? What nerve is a trigeminal nerve? Nerve number 5? Let me look it up. Neuralgia. Yeah, 5. Cranial nerve number 5. Somebody says 3. So it's a trigeminal nerve is nerve number, is it 5? The 5th nerve, yeah. So let's look at, let's just run through the different cranial nerves. All right. And as I said, there is a mnemonic, so you have to just find the one that you can remember and then work with it from there. When you go in the exam, just make sure you write it down. The first thing you put on the paper, you understand, because it might come back. Is this NCLEX style? Well, we're trying to just study, you know, it's NCLEX style questions, yes. But try to just kind of study a little bit broader with the questions that we have here, Natalie. All right, so cranial nerve 1 is the olfactory nerve that is responsible for the sense of smell. Cranial nerve 2 is the optic nerve, which controls vision. 3, oculomotor nerve, which helps with the eye movement and pupil adjustment. Cranial nerve 4 is the trochlear nerve, which controls your eye movement. 5, trigeminal nerve, provides sensation to the face and helps with chewing. 6, abducens nerve, which controls a specific eye movement. 7, facial nerve, controls facial expression. 8, vestibulocochlear nerve, which is responsible for hearing and balance. 9 is the glossopharyngeal nerve, which involves taste, swallowing, and salivation. 10, vagus nerve, which controls various visceral functions in the chest and abdomen. 11, which is the accessory or your spinal accessory nerve, which controls muscles in the neck. And then 12 is the hypoglossal nerve, which controls your tongue movement. All right. And as I said, there are so many different mnemonics out there for you to remember. Choose the one that you can remember and then from there. All right. Just know what they're responsible for. All right. A client with a suspected epidural hematoma after trauma has a brief loss of consciousness, lucid interval, then rapid decline. The most likely vessel injured is A, the middle meningeal artery, B, superior sagittal sinus, C, posterior communicating artery, or D, cortical vein. So you have a patient that was involved in an accident, and the client is suspected to have an epidural hematoma after trauma, and as a brief loss of consciousness, lucid interval, then rapid decline. The most likely vessel injured is A, middle meningeal artery, B, superior sagittal sinus, C, posterior communicating artery, or D, cortical vein. This question, I don't know how many persons will know it for the NCLEX, but this one does seem hard. Neuro is not always, was never my thing. Neuro is never my thing, you know. So I know a lot of persons probably still struggle with neuro to date. Jane says C. Okay. So Jane says C, posterior communicating artery. Carousel says A with a question mark, middle meningeal artery. Okay. All right, so yes, you're correct, Carousel. All right, the middle meningeal artery. So epidural hematoma with lucid interval, commonly from middle meningeal artery laceration, tend to have the brief loss of consciousness, lucid interval, then rapid decline. All right, so middle meningeal artery. So if you're suspecting epidural hematoma after trauma, then epidural hematoma with lucid interval is pretty common. All right, so I only guessed. Well, you guessed right. You have to save the patient. You have to save the patient. All right. Which is an early sign of normal pressure hydrocephalus. All right. Which is an early sign of normal pressure hydrocephalus? Is it A, gait disturbance, urinary incontinence and dementia? B, rapid onset coma, C, isolated optic neuritis, or D, progressive peripheral neuropathy? So which is an early sign of normal pressure hydrocephalus? A, gait disturbance, urinary incontinence and dementia, B, rapid onset coma, C, isolated optic neuritis, or D, progressive peripheral neuropathy? So Champagne says A, gait disturbance, urinary incontinence, and dementia. Do we have anyone else? So, all right. So let's look at that. So what is that? Normal pressure hydrocephalus. All right, so normal pressure hydrocephalus, or NPH, is a condition where there is an excessive buildup of CSF in the brain's ventricles. This buildup occurs despite the pressure of the CSF being within normal limits. All right. So as it says, normal pressure hydrocephalus. So there's a buildup of pressure in the brain ventricle, but the pressure is within normal limits. All right. So that's normal pressure hydrocephalus. So the exact cause is unknown. However, some potential factors include head injury, brain infection or inflammation, brain tumor. All right. And so the patient can tend to have cognitive decline. Example, memory loss, confusion, difficulty concentrating. They can have gait disturbances where they're having unsteady walking, difficulty with, their balance, urinary incontinence, headache, mood changes. All right, and definitely you want to ask the doctor about an MRI for the scan for this patient. And a lot of times these patients will tend to get a VP shunt to help with, getting rid of that, excess fluid. So sometimes they'll drain that fluid from the brain into their abdomen there, where it becomes absorbed. All right, so just in case we never know, now we know. All right, so which is an early sign of normal pressure hydrocephalus? The answer is A, gait disturbance, urinary incontinence, and dementia. All right. Rapid onset coma is out. Isolated optic neuritis progressive. So the classic triad of NPH is gait disturbance, urinary incontinence, and cognitive impairment. All right. All right. In a patient with ischemic stroke, which time window is critical for mechanical thrombectomy benefit? So in a patient with ischemic stroke, which time window is critical for mechanical thrombectomy benefit? Is it A, up to 24 hours in selected patients, B, only within 1 hour, C, no later than 3 hours, D, not used after 6 hours under any circumstance? So I have a patient with ischemic stroke. Which time window is critical for mechanical thrombectomy benefit? A, up to 24 hours in selected patients. B, only within 1 hour. C, no later than 3 hours. Or D, not used after 3 hours under any circumstance. So I have a patient that has ischemic stroke. Which time window is critical for mechanical thrombectomy benefit? Up to 24 hours, A. B, only within 1 hour. C, no later than 3 hours. D, not used after 6 hours under any circumstance. So Carousel says C, which is no later than 3 hours. Okay. We have anybody else? Mam Dam says C as well. Okay. I know of 4.5 hours though. Okay. All right. That's the one I know. So this one is actually A. It says up to 24 hours in selected patients with imaging selection. So you have to have your CT scan that is in favor of. And then the time windows have expanded with selection. So that's what they're saying. Critical for thrombectomy benefits. So let's look at this. Ischemic stroke and thrombectomy. All right. So the standard thrombectomy window is up to 6 hours after stroke onset. This is the recommended time window for most patients. Thrombectomy within this time frame has been shown to significantly improve outcomes such as survival and disability. All right, extended thrombectomy window is going to be 6 to 24 hours after the stroke onset. All right. So thrombectomy may be considered even if it is more than 6 hours after the stroke onset. This is known as the extended window. Patients who may be eligible for extended thrombectomy include those patients with large vessel occlusion, mild to moderate symptoms, or perfusion imaging, the CT or the MRI shows a salvageable brain tissue. All right. So anywhere up to 24 hours, but it is best for any time period between like up to 6 hours. But depending on like their imaging results and if it is mild to moderate in terms of their symptoms, and if they have large vessel occlusion, then the 6 to 24 hours time frame is considered as your extended thrombectomy window. All right. So for this one, it says a patient with ischemic stroke, which time period is critical for mechanical thrombectomy benefits? So anywhere that is up to 24 hours in selected patients when they have their imaging done is the most appropriate one for them. All right. All right. A client post craniotomy has CSF draining from incision site. Which action should the nurse take? So you had a patient that went in for craniotomy and the patient now has CSF draining from the site. Which action should the nurse take first? A, notify the neurosurgeon immediately and maintain wound dressing, minimizing movement. B, apply firm pressure and attempt to stop the leak. C, elevate the head of the bed flat and ambulate. D, change dressing vigorously to clean wound. So you have a client that is post craniotomy that has CSF draining from incision site. Which action should the nurse take first? A, notify the neurosurgeon immediately and maintain wound dressing, minimizing movement. B, apply firm pressure and attempt to stop the leak. C, elevate the head of the bed, flat and ambulate. D, change dressing vigorously to clean wound. So what are you going to be doing? If you have this patient that comes out of surgery after doing their, their procedure, post craniotomy, and is having CSF draining from their incision site, what is it that you're going to do for this patient? A, B, C, or D? What are you going to be doing? Carousel says A, notify the neurosurgeon immediately and maintain wound dressing, minimizing movement. Do we have anyone else with another answer? Yes. So mom says yes. I guess she's saying A as well. Definitely, you want to do that. All right. Change dressing vigorously to clean wound. Would you be doing that for, your patient that just had the surgery done? Like cleaning the wound, the site vigorously? Would you be doing that? No, you want to be doing that vigorous cleaning. All right. You want to try to, is C a typo? I think C is like a typo. It's more gonna be elevate the head of the bed, elevate the head of the bed and ambulate. I think the flat is supposed to be out. Yeah. So the flat should be out. You can't elevate the head of the bed flat, but keep on reading. All right, so you definitely want to notify the neurosurgeon immediately and maintain wound dressing, minimize movement. All right, because you don't want it to be a case where you keep on moving and causing that, that pressure, the fluid to be leaking because of the pressure that is built up there. All right, applying firm pressure and attempt to stop the leak. No, you're not going to try to stop the leak. All right, you're not going to try to stop the leak. Do not apply any pressure that could cause any, like forcing the contents back in. So no. All right, call the neurosurgeon and then let them come and deal with that part. All right, limit the amount of movement with the patient. And then, you can always go and add like additional dressing on top. If it's a case where it's just soak, say, because anywhere that is going to be too moist is going to attract bacteria. So I don't think that surgeon is going to take forever to come, but at least, just apply like, your sterile gauze to that area and just cover it up nicely until he gets there. All right, so CSF leak after craniotomy needs prompt neurosurgical notification and careful handling to avoid infection. And that's the other thing. You don't want to introduce any form of bacteria into that patient's system. All right, don't want to cause any problem with that. So do not apply pressure that could cause any, force and pushing back that contents in. Let the neurosurgeon come and deal with their business. All right. Elevate the head of the bed. You can probably go like your 30 degrees, but you don't want to be too high up. That is going to cause increase in that pressure and further cause leakage from that site. All right. Change dressing vigorously to clean wound. That time, as I say, you're not going to be cleaning any wound or anything. Just apply additional gauze, sterile gauze to the one that is there, and then wait until that provider comes. All right. So that's the most appropriate thing to do at that time. Notify the neurosurgeon immediately and maintain the wound dressing and minimize movement of the patient. Can elevate the bed up to 30 degrees. Definitely, definitely. All right. Miss G, welcome, welcome, welcome. How are you doing? All right. You have a patient who is still on the neurological, the neuro floor. So during neurological assessment, the nurse notes flaccid paralysis and loss of reflexes after spinal shock. This indicates A, spinal shock, temporary loss of reflexes versus permanent neurogenic findings. Monitor for a return of reflexes. B, complete recovery imminent. C, a peripheral neuropathy after rather than a spinal cord injury, or D, that autonomic function will be preserved. So during a neurologic assessment, the nurse notes flaccid paralysis and loss of reflexes after a spinal shock. This indicates a spinal shock versus permanent neurogenic findings. B, complete recovery is imminent. C, a peripheral neuropathy rather than spinal cord injury. Or D, that autonomic function will be preserved. So if you have a patient and you're doing your assessment on them and you notice that they're having flaccid paralysis and loss of reflexes after a spinal shock, what is that indicating to you? Is it A, a spinal shock versus a permanent neurogenic finding? B, complete recovery is imminent. C, a peripheral neuropathy rather than spinal cord injury. Or D, that autonomic function will be preserved. What's the answer for that one? C, a peripheral neuropathy rather than a spinal cord injury. That's C. Okay. So let's look up spinal shock. So spinal shock is a temporary state of physiological dysfunction that occurs immediately after spinal cord injury. It is characterized by loss of motor, sensory, and autonomic functions below the level of injury, caused by trauma to the spinal cord, such as your MVAs, fall, sport injuries, spinal cord tumors, infection. A lot of times the patient might have the symptoms of like loss of muscle tone, reflexes below the injury level, loss of sensation, including pain, temperature, touch, paralysis, loss of bladder and bowel control. They might also have autonomic dysfunction, such as the hypotension, which is a low blood pressure, bradycardia, which is a slow heart rate, loss of sweating, and difficulty breathing. It typically lasts for a few days to weeks. However, in some cases, it may persist longer. So during neurological assessment, the nurse notes flaccid paralysis and loss of reflexes after spinal shock. This indicates a spinal shock versus permanent neurogenic findings, all right? Because the spinal shock, it's temporary loss of the reflexes, and the permanent neurogenic findings, you have to monitor for like your return of your reflexes there. So the answer is A, the spinal shock, all right? It causes transient areflexia and flaccidity, and the reflexes may return after it might return later, indicating the level of injury. So we just have to read up on a different kind of shock. All right, just have to gonna read up on that so we can have a better understanding. But that's the answer for that one. All right. Any question on that one? All right. A child presents with febrile seizure. What we know about febrile seizure? What's causing that kind of seizure? Let me see if we're still up and running. What's causing that seizure? If somebody comes in and they say that the child is having a febrile seizure, or if an adult comes in and says, we just have a febrile seizure, would you believe them? Would you believe that person? Do we normally see adults with febrile seizure? No. Panther walk. Hola. Welcome, welcome. No, we don't normally see adults with febrile seizure. A lot of times it's a pediatric case, all right? So a lot of times they tend to have the children having fever and then they start having seizures because of that. So once you control the fever, you control the seizure normally goes away, all right? So if you hear somebody says, oh, the child is having a seizure, and you realize the temperature is 105, try to get down that temperature and then you will correct the seizure. All right, so a child presents with febrile seizure lasting 2 minutes. Which is the appropriate action? A, protect airway and observe antipyretics and evaluate for serious infection. B, immediately intubate and give lorazepam. C, start long-term anticonvulsants. D, send home without follow-up. So a child presents with febrile seizure lasting 2 minutes. Which is the appropriate action? A, protect airway and observe. Also, you're going to give your antipyretics and evaluate for serious infection. B, immediately intubate and give lorazepam. C, start long-term anticonvulsants. And D, send home without follow-up. Which is your answer? And thank you guys for tuning in if you're just joining in. All right, so Panther Walk says D, send home without follow-up. Do we have anyone else with another answer? Natalie says A, protect airway and observe. You'll also give antipyretics and evaluate for serious infection. Definitely, that's the answer there at A. All right. So most febrile seizures are brief. You want to just go ahead, protect their airway, treat the fever, and then assess for any serious infection. You want to know why that child is having that fever or that patient is having that fever. And then from there, you treat them for that. All right, prolonged seizures greater than 5 minutes usually needs emergent treatment. All right, so anything that is under the 2 minutes is pretty okay. Not okay, but in terms of, just treating them with the antipyretics and observing them. But anything that is longer, then probably there is something else going on as well. Immediately intubate and give lorazepam. No, we're not going to do that. All right. Who would you be intubating? If you have a patient that is having seizure, continuous seizure, and, why would you be thinking that you want to intubate that patient? So if you have somebody that is having continuous seizure, they're in status epilepticus, they can't control their airway. You can't control their airway. They're at risk for for aspiration. They're unconscious, changing their level of consciousness. Definitely you think about those patients, your status epilepticus patients, for intubating them and giving them, those anticonvulsant medication. Start long-term anticonvulsants is not really needed right now, the long-term, all right? You'll definitely be on maintenance medication, but for now, what is it that they need? You'll do that. Send home without follow-up. A lot of times, we send home patients, they need follow-up. So that one without the follow-up, no, you still have them follow up with their pediatrician, not necessarily a neurologist, because a lot of times, as I say, if you identify the source of the infection, the fever, why are they having that elevation in their temperature, then usually they can follow up with their regular pediatrician. But if it is anything else that is related to like a true seizure activity, then, definitely they'll need their follow-up with their neurologist. All right. A patient with chronic alcohol use presents with confusion, ophthalmoplegia, and ataxia. Which deficiency is suspected? So I have a patient with chronic alcohol who presents with confusion, ophthalmoplegia, and ataxia. Which deficiency is suspected? A, thiamine or vitamin B1 deficiency. B, vitamin B12 deficiency only. C, niacin deficiency or vitamin C deficiency as option D. So you have a patient with chronic alcohol use that presents with confusion, ophthalmoplegia, and ataxia. Which deficiency is suspected? A, thiamine or vitamin B1 deficiency, Wernicke encephalopathy, or B, vitamin B12 deficiency only, C, niacin deficiency, or D, vitamin C deficiency. Which is your answer? Thiamine deficiency. Okay. Champagne is saying A as well. Definitely. So your A, your thiamine deficiency, or your B1 deficiency is what is suspected here. All right. B, vitamin B12 deficiency only. As I say, use the process of elimination. Anytime you see they have an answer that says only, just go ahead and put an X beside it, because that's not only the answer. Never choose that one. Niacin deficiency, vitamin C deficiency are not the one that is common with chronic alcohol use. So no, a lot of times you might see your patient having the banana bag and they're giving them thiamine, they're giving them, what else they're doing, the folic acid, a lot of vitamins, just because those patients are chronic alcoholics, or, they've ingested a lot of alcohol. Let's not say alcoholics, but they are chronic alcohol users, and so they tend to be deficient in a lot of vitamins such as your, your B12 as well as your thiamine. And so you want to go ahead and just replace those because you want to prevent your Wernicke encephalopathy, all right, which usually has the confusion, ophthalmoplegia, and the ataxia. So you want to go ahead and treat promptly with your IV thiamine, all right? Always go ahead and think about that. All right. Oh, let's get the live tap up to 4,500, please. And thank you. You can also share it. Who is this following? Is this Ephesians 5 verse 25? Hello, how are you doing? Yeah, I think that's what I see. Ephesians 5 verse 25. Let's see what Ephesians 5 verse 25 says while we tap up the live. Ephesians 5 verse 25 says, husbands, love your wives just as Christ loved the church and gave himself up for her. This verse instructs husbands to exhibit a sacrificial, selfless, and unconditional love for their wives, modeling it after Christ's profound love and sacrifice for the church. All right, so thank you for joining in Ephesians 5 verse 25. Ekaterina, hello. Nadine, welcome. All right, so let's continue. Oh, thank you for that, 4-5. All right, so post-operative patient with spinal anesthesia develops severe headache that improves when lying flat. The diagnosis and intervention for this patient is going to be a post-dural puncture headache. You're going to treat with bed rest, hydration, caffeine, and possibly epidural blood patch. You also have B, which is a migraine. You can give sumatriptan. C is a subarachnoid hemorrhage. You're going to get an immediate CT scan. Or D, which is meningitis, you're going to start IV antibiotics. So post-operative patient with spinal anesthesia develops severe headache that improves when lying flat. What is the diagnosis and how you go about with treating? Is it A, a post-dural puncture headache that you're going to be treating with bed rest, hydration, caffeine, and possibly an epidural blood patch? Is it B, migraine that you're going to be giving sumatriptan? C, subarachnoid hemorrhage that you're going to get a CT scan? Or D, meningitis that you're going to start your antibiotics? Which of them is it? So this patient post-op is having, who had spinal anesthesia, develops severe headache that improves when lying flat. What is your diagnosis? What are you thinking and how you're going to be treating? So Champagne says A, post-dural puncture headache. You're going to treat with bed rest, hydration, and possibly epidural blood patch. Okay. Do we have anyone else with another answer option? Bed. All right, so, but the answer is actually A. All right, the answer is actually A. The post-dural puncture headache. So you have a patient that is coming out of surgery and is or was treated using spinal anesthesia. The patient develops severe headache that improves when lying flat. This patient is exhibiting the post-epidural puncture headache that usually you treat with bed rest, hydration, caffeine, and possibly epidural blood patch. All right. So post-dural puncture headache classically worsen when they're upright. They're better when flat. The blood patch is effective when conservative measures fail. So after they've tried all of those other treatment and it doesn't work, then a lot of times these patients will get admitted and they'll do the blood patch. All right, and usually that will help with their headache. All right, but the caffeine is something that is very good as well, and with the hydration, rest, and everything. Okay. Meningitis, would it be meningitis? No. You know, based on the presentation of meningitis, that wouldn't be it. Subarachnoid hemorrhage as well, you know, based on the presentation for subarachnoid hemorrhage, where it's like, you know, one of those sudden onset, worst pain of your life, that would be a little bit different in terms of the presentation here with your spinal anesthesia. So just look at the presentation, and then from there you can always do your, process of elimination for the answer. All right. What time is it? We have 5 more minutes. Gonna do 2 more questions. All right. A client with suspected bacterial brain abscess. A client with suspected bacterial brain abscess. Which is the least likely feature? A. Focal neurologic deficits, fever, headache, and seizures. B. Rapid global cognitive decline over hours only. C. Ring enhancing lesion on MRI. Or D. Elevated white blood cell count and ESR level. So you have a client with suspected bacterial brain abscess. Which is the least likely feature? Focal neurologic deficits, fever, headache, seizures. B. Rapid global cognitive decline over hours only. C. Ring enhancing lesion on the MRI. Or D. Elevated white blood cell count and ESR level. So D, elevated white blood cell and ESR. Champagne says D. All right, so remember, so this patient has suspected bacterial brain abscess. So if we don't really know which one of them, always use the process of elimination. So try to find out what is common for a patient that has a bacterial brain abscess or bacterial infection. So elevated white blood cell count, is that something that is common for a patient that has an infection on board? The elevation in the white blood cell count and the ESR level, is that something that is normal? So if that is normal, so a client with suspected bacterial brain abscess, which is the least likely feature? So the patient is definitely going to have elevated white blood cell, so that's not going to be the least likely feature. All right, so we'll mark that one off because that is pretty accurate for any patient that has like an infection on board. Focal neurologic deficits, fever, headache, and seizure. So if you have a brain abscess, do you normally have like neurologic deficits, fever, headache, seizures? Definitely, with the bacterial brain abscess. So even if you don't have the full-blown seizure, they tend to have neurologic deficits, they tend to have fever and the headache, all right? So which is the least likely feature? That is something that is common, so you'll tick that one. So that's not it. Rapid global cognitive decline over hours only, or the ring enhancing lesion on MRI. Which of those two would you choose as the least likely feature for bacterial brain abscess? Is it the rapid global cognitive decline over hours only, or ring enhancing lesion on MRI? The answer is going to be the rapid global cognitive decline over hours only. Brain abscess typically causes focal signs and subacute symptoms. Pure rapid global decline over hours suggests other acute processes. All right. So the answer is the rapid global cognitive decline over hours only. The ring enhancing lesion on the MRI is common for your bacterial infection there. So use the process of elimination. So it says, which is the least likely feature? All right. So all of these are likely features of a bacterial brain abscess or of an abscess. So you'll use the process of elimination to get rid of the ones that are common to that condition. And then from there, you can battle between the other two options. All right. And then the last one we're going to be doing is a patient on warfarin has an intracerebral hemorrhage. Which reversal is fastest and preferred in life-threatening bleeding? So you have a patient that is on warfarin. What is the antidote for warfarin? So if you have a patient that is being overdosed on warfarin, what is it that you're going to be giving them? So A, prothrombin complex concentrate plus vitamin K. B, fresh frozen plasma only. C, wait for warfarin to clear, or D, platelet transfusion. So you have a patient on warfarin who has intracerebral hemorrhage. Which reversal is fastest and preferred in life-threatening bleeding? A, prothrombin complex concentrate plus vitamin K, fresh frozen plasma only, wait for warfarin to clear, or D, platelet transfusion. Kaidine says vitamin K. Champagne says the prothrombin with the vitamin K, definitely. All right. So those two, the prothrombin complex concentrate plus the vitamin K, all right, are used in life-threatening warfarin-associated bleeding. All right. So fresh frozen plasma only, as I say, if you see any option that says only, always just go ahead and ignore that. All right. The only there is the problem. Wait for warfarin to clear. We're going to put an X beside that, platelet transfusion. We're going to put a, eventually, probably this patient will get some platelet transfusion. All right. This patient is going to get some platelet transfusion. So, but the one that is the fastest, for the reversal is going to be the prothrombin complex concentrate with your vitamin K. All right. And then from there. All right. So, what time is it? It's 9 o'clock, right? Oh, we have 6 more minutes. All right, so let's do one more. Let's do one more question. All right, which is true about nimodipine? What kind of drug is nimodipine? What kind of drug is nimodipine? Kidine. I'm sorry. Yeah, we're here from 7 o'clock. Usually I try to go until 11 o'clock. We have like 100 questions. But I'm trying to, buckle down on my time. I have some notes to go and do. So, yeah, I'm kind of keeping it at 2 hours. So you can join us next week. No, not next week. Thursday. We'll be here on Thursday. So we do the live at 7 p.m. on Tuesdays and Thursdays. 7 to, 8 o'clock. Well, most of the time we go a little bit longer. But it's going to be probably like 2 hours. I'm going to do for 2 hours. All right. On Thursday, I might go a little bit longer because I don't have any work. No, I have a meeting at 9. But usually I don't have any work on Thursday. So I'll go a little bit longer on Thursday night. So on Friday. I don't have any work on Friday and Thursday. So yeah. So I might go a little bit longer on Thursday nights. But I'm trying to, stick with the time. All right. So what kind of drug is nimodipine? Nimodipine is a calcium channel blocker. Okay, nice. All right, so you have a patient that is, yes, it's a calcium channel blocker. All right, so you have a patient that is on nimodipine. So which is true about nimodipine after subarachnoid hemorrhage? A, nimodipine is given to reduce cerebral vasospasm and improve outcome. B, it is an anticoagulant preferred in a subarachnoid hemorrhage. B, it increases intracranial pressure and should be avoided. Or D, it is only used in ischemic stroke. So you have a patient that is on nimodipine. This patient has also had a subarachnoid hemorrhage. Which is true about nimodipine after subarachnoid hemorrhage? Is it A, nimodipine is given to reduce cerebral vasospasm and improve outcome? B, it is an anticoagulant preferred in subarachnoid hemorrhage. C, it increases intracranial pressure and should be avoided. Or D, it is only used in ischemic stroke. It is preferred for subarachnoid hemorrhage. B.
Are you going to exercise tomorrow?
Yes, Dorian. So B, it is an anticoagulant preferred in subarachnoid hemorrhage. Champagne. So what kind of drug is nimodipine? What class of drug is nimodipine? Is it an anticoagulant, antidiuretic, calcium channel blocker? So once you know the class of the drug, so always try to go ahead and study the class of the drug and, some of the different drugs that come under, each class. All right. So the nimodipine is a calcium channel blocker. All right. B says it is an anticoagulant. No, and it's not preferred in subarachnoid hemorrhage because the patient is already bleeding. All right, so it's not something that you'd want to give the patient. You don't want to give this patient an anticoagulant. All right, because that's going to worsen the bleeding for that patient. It increases intracranial pressure and should be avoided. Nimodipine. Is it nimodipine that they use in glaucoma? Do they use nimodipine? Let's see if they use that in glaucoma. They use that in which drug they use in glaucoma for? That has a name. Yeah. So nimodipine is also used in glaucoma treatment. All right, particularly normal tension glaucoma, by improving ocular hemodynamics and retinal circulation. Though it is not a standard primary treatment, can have serious side effect. Okay. So B is out because the class of the drug is not anticoagulant, and you don't want to give an anticoagulant in subarachnoid hemorrhage patient. All right. It increases intracranial pressure and should be avoided. So nimodipine does, so it plays a role in glaucoma treatment with normal tension by improving ocular. Understand that. So it can increase blood flow to the optic nerve. Okay, so it increases intracranial pressure and should be avoided. Okay, it is only used in ischemic stroke. So nimodipine it reduces vasospasm. It reduces vasospasm risk after subarachnoid hemorrhage. So that is the role of it in your subarachnoid hemorrhage patient. All right, it is given to reduce cerebral vasospasm and improve patient in your subarachnoid hemorrhage patient. The other options are going to be incorrect. All right, the other options are incorrect for this patient. All right, so try to remember, study the class of the drugs, some of the common medications that comes under them, and try to understand like the mechanism of action for them. All right. So Kidim is a psychiatric nurse practitioner. I want to do the FNP certification. Okay, nice. Yeah, that's nice. Tamarivia, welcome. Delius, welcome. All right, and just in case you're joining us for the first time, as usual, I'm Stacy. All right, I'm Stacy. You can follow me on the page here at ThinkNursing. You can also follow me on YouTube at ThinkNursing. The full live sessions are over there with all the live stream regarding study and more, you know. You can always go over there and check it out and ask me any questions regarding nursing travel, transition into the States, things like that with a recruiting company as a nurse. I talk a lot about that. So definitely go ahead and subscribe and follow, and we can become friends. You understand? Reach out to me, Kidim. I definitely want to have you on my podcast. All right. We want to have a little sit down, a little chit chat. Can talk a little bit about being a psychiatric nurse practitioner, what it is like, so persons can hear a little bit more from the horse's mouth about, working as a nurse practitioner in psychiatry, or, how you transition, things like that. That's what I'm working on with my YouTube page. So definitely, if you're interested, you can always send me your information. You can DM me and we can have a chit chat. All right. And just kind of have more persons know more about our role as nurses, nurse practitioners, LPN, CNAs, home health aid, whatever capacity in the health industry you are working in. I'd love to feature you on my page. All right. But yeah, so definitely join me on Thursdays, and on Tuesday we'll be doing musculoskeletal on Thursday. I'm trying to do the systems first, and then we can always do additional. We'll just do like multiple questions, different section of the NCLEX, or not, of the NCLEX, but it should help just about anybody that is studying for their boards exam, or if you just need a refresher. Me need a refresher because some of these things, like, from nursing school, miss them. We not them again, you understand? So going through these questions with you, it's also helping me as well. So it's for anybody that is interested and want a little refresher course. We do that here. All right, but I'm gonna do some notes now. I'm not going to bed. I'm not going to my bed. I'm gonna be sitting up for the next few hours to try and get some notes completed, and then I'll go to my bed later on. You can join me tomorrow evening for Peloton ride. All right, yeah, we're not doing any more morning class for no Peloton. It's just too much. Yeah, make me yawn too much. You're not supposed to hear me talk about this yawning thing. Yeah, man. After we finish, I'm like so tired. I'm like so tired driving to work. And you know, me spend a lot of time on the road, so that's a no-no. You understand? But it's so like so tiring. After doing the Peloton rides in the morning. So I'm doing it on Monday, Wednesdays, and Friday evenings at 5:30. And I'll stream it on Tuesdays and on Thursdays. I'll do something like, you know, light, probably jump rope or something, and then that's it. All right, but until then, it was nice having you guys on the page here. All right, I mean, I'm not a friend now, so whoever follow me, come back and follow. No. All right, so we'll see you in the next live. I'll see you in the next live. Champagne, thank you so much for being so active on the page. Really appreciate you. Carousel, Kidim, it was nice meeting you as well. And all the other folks, Temi. Shells is blessed. Thank you so much, Maxine. And I think I saw, what's her name again? Blake Grove. No, that wasn't her name. Yeah, that was her name. But yeah, I see you guys as usual. Thank you so much. All right, so anyways, I'm gonna go enjoy your night now and stay safe. All right.